Okay, so what we're going to be looking at here, we're going to be discussing musculoskeletal conditions and disorders. So we're going to be kind of discussing some of the more common musculoskeletal conditions and disorders and mentioning how we could, how as an exercise professional, you can address and help individuals deal with these conditions. And we'll talk a little bit about prevention as well, both in class and in the lab. So we'll kind of be addressing this on both ends. Obviously, if you could prevent a lot of these things from occurring, that's obviously better from just just a personal standpoint and just as far as stress on the on our healthcare system. So we're going to start out talking about a very common thing we see, just various disorders of the spine and the associated musculature. So again, any type of injury, and speaking from the standpoint of an athletic trainer as well as a strength conditioning professional, spine problems tend to have various causes. In other words, many times when you're looking at an individual who has, for instance, and typically when we're talking about spine issues, we're talking about the low back and low back pain. There's a lot of structures in that area and a lot of possible pain-causing sort of sources that can be an issue. And again, the key with this and with all of the things we're going to talk about is many times the treatments with the exercise has to be really individualized. So throughout all these conditions we're going to be discussing, again, the guidelines that are going to be given are going to be kind of general, and some of them will actually seem repetitive because there are things that, for the most part, at least initially for most individuals, they can usually tolerate and do and is usually pretty safe. And we're going to be including, obviously, low back pain. That's, as I had discussed, that's probably the most common issue we're going to be seeing here as it relates to the spine. I mean, you can have some pain in the thoracic and in the cervical region as well, but low back pain, as you'll see, as we just kind of talk about numbers and statistics, tends to be a very common thing that individuals look at with kind of dealing. And we're going to talk about posture disorders. We're going to talk about them separately and just talk about how we can address postural issues and why sometimes posture is a source of pain. So looking at low back pain, and again, low back pain, again, typically even when an individual gets assessed for low back pain, so they go and see a healthcare professional about their back pain, many times the diagnosis is a very general. They get diagnosed with like what we'd call mechanical low back pain. And when we look at low back pain, it's defined as pain, discomfort localized below the costal margin and above the inferior gluteal folds with or without leg pain. So again, sometimes individuals, again, depending upon what the source of their pain is, there could be some what we would call referred pain or radiating pain, depending upon whether you're talking about a nerve being irritated. Again, if the cause of the pain is unknown, it's just referred to as non-specific low back pain, or as I had talked about, or as I had discussed and talked about, it gets referred to as mechanical lower back pain. And again, low back pain is going to be kind of characterized based upon the duration of the low back pain. So again, when you look at whether you're talking acute, so acute, they'll usually define it as less than 6 weeks, subacute around 6 to 12 weeks, and then chronic greater than 12 weeks. Another term you'll hear a lot of times, anytime a person has some sort of issue and they don't know the cause, you'll hear the term idiopathic. So you'll sometimes hear that as well. Idiopathic just basically means there's no specific known cause. So that would be another term that you would see possibly getting used if for instance, in the case of low back pain, they're really not sure why. And again, many times with low back pain, as I had said, there are multiple issues and structures involved. So again, in developed countries, again, 58 to 70% of individuals have low back pain at some point, and that tends to increase as it relates to age. And again, low back pain results in substantial costs. So in the costs, you look at medical office visits, medications, surgeries, diagnostic tests that kind of all go into assessing and diagnosing somebody with low back pain does result in substantial costs. So again, it's something that we even could kind of look at, again, as promoting prevention. And I'm a big fan of promoting prevention because, again, if you could prevent something from happening or worsening, it kind of saves you a lot on that other end. And again, it just in general for, again, just the overburdening of the healthcare system, as we've talked about previously with some of these things, it makes things better overall. So again, the onset of low back pain is associated with a variety of causes. So we look at some of the general causes. So again, your physical attributes, age, weight, height, fitness level, occupational hazards. So if you have an occupation that's very physically demanding, any type of heavy lifting or any type of activity that would cause whole body vibration could certainly be a cause of low back pain. And as I said, there's various structures. So if you remember going back to your anatomy, various body structures can be affected. So you have the intervertebral joints, you have the discs, you have the musculature, you have the nervous system, you have the nerve roots, which immediately exit the spine. So all of this can cause a lot of increasing symptom variability, meaning that, in all likelihood, somebody with low back pain kind of has multiple issues. You can even throw in like the ligaments. So basically any of the soft tissue, the muscles, the ligaments, the fascia can all be a source of pain. Again, the discs could be a source of pain. The nerve roots could be a source of pain, and the intervertebral joints, as I had said. So all of those can be sources of pain. So as we do with all of our conditions we're going to be looking at, we'll look at the medications that are commonly given to individuals and kind of make you aware of, some of the possible side effects. So non-steroidal anti-inflammatory drugs are your NSAIDs. And again, for some of these, I'll give examples. For others, what I would always tell you is look to see if your book does give examples. So I kind of want to keep you a little actively engaged with your reading and everything as we're kind of going through this. So your non-steroidal anti-inflammatory drugs, think of things like your naproxen, ibuprofen. Those are some things that would be considered non-steroidal anti-inflammatory drugs. There's no short-term effects on activity, but some studies have shown that it actually may slow muscle regeneration. Long-term effects, and this is where you get a little concerned about long-term use of these. GI discomfort, kidney dysfunction, elevated risk of heart attack and stroke are all things that are found with non-steroidal anti-inflammatory drugs. Probably the GI discomfort being the thing that a lot of people end up typically having issues with, but some of these more serious things could become an issue. So we got to watch how long-term these get used. You have what are then get classified as your non-opioid analgesics. So these are these tend to not have a whole lot of side effects unless an individual would overdose on them. And again, probably the most common one here is your acetaminophen or Tylenol is a non-opioid analgesic. Again, Tylenol is not an anti-inflammatory because it doesn't have any effect on inflammation. It's just strictly a pain reliever. Some other things commonly used: topical capsaicin plasters. Again, there's typically no side effects with any type of topical medications used, except maybe occasionally sometimes you can get some superficial skin irritation from them, but really there's no significant systemic effects typically from those. Many times individuals with low back pain, it's not uncommon for them to get prescribed an antispasmodic muscle relaxant. Valium is a common one. There's various other types of skeletal muscle relaxants that get given or prescribed. The common things you see with this are dizziness and drowsiness. So usually muscle relaxants are usually given to individuals typically before bed. So usually the suggestion is take them before you go to sleep because they can certainly make you drowsy. Selective serotonin reuptake inhibitors. So these are commonly prescribed for people with depression, but they can also be prescribed many times for individuals with low back pain. So some types of SSRIs, your Prozac, Zoloft, Paxil. Again, typically they're classified as antidepressants, but they can be utilized in the treatment of low back pain. Mild dizziness and mild drowsiness are probably the most common things that you get with them. You can also get headaches as well. Again, they appear to be less severe usually, the side effects with these, and they don't tend to affect the response to exercise. One thing to note with this, I don't have them listed up here, but opioids are another thing that or your opioid pain relievers. The issues with them is they can obviously have significant side effects, and also there's the potential for addiction with those as well. Typically, if an opioid would get prescribed, it's going to be only prescribed for a short amount of time, and it's usually going to have to be somebody who is having significant pain from those. And we obviously know with opioids, things like hand-eye coordination and everything and can be affected, plus they can also cause drowsiness as well. So your exercise recommendations for individuals with low back pain, and again, some of these things could also be prescribed as a preventative standpoint, and we'll talk about both in class and in lab. We'll talk about like some specific exercises that individuals can use. The idea with whether it's preventing or kind of using exercise to treat low back pain, you want to look at doing things that aren't, we obviously can exercise the musculature and everything around the spine, but we want to make sure that we're utilizing exercises that are going to not stress the spine. Obviously, everything you do is going to stress the spine as it relates to a lot of the exercise to a degree, but particularly early on, and maybe for individuals who have poor muscular conditioning in this area, we really want to watch kind of what we do. The one thing to definitely note is exercise, and this tends to be the case with most things, which is obviously why we're learning about this and why there's professionals trained in this. Exercise is going to be better than complete rest. There's not many circumstances where complete rest is going to be indicated or beneficial for the person. So that's one thing to particularly note as it relates to this type of idea behind treating some of these issues. So again, and always go back to the tables. I'm going to talk about some of the things here, but make sure you're referencing the table. So table 3.1 in your text. But resistance training, again, focused on abdominal and lumbar strength. Again, 1 to 4 sets, 8 to 12 reps. And again, those aren't hard, fast rules, but that's where we'll kind of be our starting point. And again, low to moderate intensity initially. Also include some flexibility training, targeting the trunk and hip musculature. And I would even say in a lot of instances, the hip musculature in general, the recommendation here is 10-second static holds for exercises done for 3 sets. And again, that could be a starting point, and we'll kind of talk about some variations in how long it should be held for. But so I'll give you the recommendations in the textbook. We'll talk about other things, for testing purposes and everything. We'll go with those recommendations. Aerobic training should start short bouts up to about 30 minutes a day, or around 3 times a week. We'll typically do that at least to a start. Progressing to 150 to 300 minutes of moderate to vigorous exercise. Obviously, anytime there would be significant pain, you always want to make sure that you would terminate exercise. So posture conditions kind of tie into when we're looking at anything involving the spine. So again, this could obviously be looking at impacting the thoracic and cervical spine as well. So we look at posture and how we define that. It's the alignment of the head, neck, and trunk and limbs in space. You could also look at the difference between static and dynamic posture, which we'll talk about as well. Again, good posture is going to be defined as an optimal alignment that allows for efficient movement of the body without undue stress on the musculoskeletal or the nervous system. So when we look at posture, first of all, you want to find out, is posture the cause of the problem or the likely cause of the problem? And again, because essentially what happens is if the body's not in, at least near what we'd call near normal alignment, there's going to put excessive stress on tissues because you're going to have compensations occurring, and the person's not going to operate from a good starting point if their body's not kind of in this good alignment. And again, postural assessment should be conducted in a variety of static and dynamic conditions. So you kind of have your static posture, which is just kind of your stance and how you look when you're not moving, and then you have under postural assessment under dynamic conditions. So what exactly happens when we're looking at dynamic posture is when the person is moving, what happens to them? And that's important to note too, because that could bring out a lot of different muscular imbalances that you don't see when the person's just standing still and not moving. So as we're looking at posture, so as you can see, and I do have this illustration on the next slide. So you can look at it now in your book if you want, as I'm kind of talking here, but I will pull it up on the next slide, that the spine does have a natural curvature. So you either have a lordotic or an anterior convexity, or a kyphotic, which the kyphotic is going to be in the thoracic spine. So basically your cervical spine, your lumbar spine is lordotic, your thoracic spine is kyphotic, where it has an anterior concavity. So as we kind of look, and I'll kind of show you this, however, too much anterior posterior curvature is referred to hyperlordosis or hyperkyphosis. Again, it just kind of depends upon the nature of the curvature. So for instance, in the lumbar spine, if there's too much of a lordotic curve. So again, we do have a natural lordotic curve, and the reason why the spine there's multiple reasons why the spine has curves. Part of it's because developmentally what happens with the musculature and growing, but the other thing that those curvatures do allow the spine to be a little bit more tolerant to compressive forces. In other words, if our spine was just a straight structure, it wouldn't be as resistant to compressive forces. The fact that it has some curvature to it actually does allow it to withstand compression a little bit more. So number one is looking at, does someone have too much of a curve? And again, there's various, risk factors that could cause that. Again, physical, psychological stress, trauma, sporting activities, occupational behaviors are all things that could further encourage increased abnormal posture. And again, sometimes, it could, the cause could also be idiopathic. In other words, they could have bad posture. There's not necessarily a particular reason why, outside of maybe, again, some muscular imbalances and things like that. One other type of curvature, now scoliosis is always an abnormal curvature of the spine, but this would be an excessive medial lateral curvature. So this would be a lateral deviation of the spine. In this case, this would always be something that would possibly be causing problems. So because again, the spine shouldn't have that medial lateral curvature. It should be pretty much, when you're looking at it, strictly in the plane, it should be straight with just the curves that we had talked about. So it should be the anterior posterior curves that we look at are normal. It shouldn't have any medial lateral curvature to it when you're looking at the spine. So here we look at the different curves of the spine. So here we're looking at a normal posture. So when we're kind of looking at this, and what they typically refer to this, you could actually do this clinically. You could drop what's called a plumb line and have someone stand and kind of look to see how all the curves line up. And this is what we were referring to when we talk about a lordotic curve. So you can see the lordotic curve in the cervical spine, the lordotic curve in the lumbar spine, okay? So in the anterior surface, which is in the front of the body, you have a convexity of the lumbar spine and the cervical spine. When you look at the thoracic region, okay, anteriorly it's a concavity, okay? So you can see, so when you talk about a concave surface, okay, think of a cave, okay? So there you can kind of see that with the thoracic spine. Now, these curves could be exaggerated or they could be eliminated, and in either situation, there could be problems associated with that and cause obviously compensations, and they could cause compensations kind of down what we'd call the kinetic chain that could cause further problems. Here's a situation where somebody is hyperlordotic, and you can kind of see it not only affecting the lumbar spine, so you're getting the increased lordotic curve at the spine, that's also causing what we call up here a forward head posture as the head's kind of coming forward. Here you have a hyperkyphotic, so you have increased kyphosis. That's also known for bringing the head forward as well and causing problems not only in the thoracic spine but in the cervical spine. And over here you have a scoliotic posture. So with scoliosis, we'll talk about that and as far as how that gets treated. So for one of the things when you talk about scoliosis as far as the treatment and the intervention is, one, how much of a curve is there and what exactly is the curve doing? Is the curve what we would call a functional scoliosis, where a functional scoliosis is when there's a muscular imbalance causing the lateral deviation, or a structural scoliosis where it's the actual structure of the spine that's curved. In other words, with a functional scoliosis, you could kind of change it. If you work on, say someone has a leg length discrepancy or something like that, you could kind of reverse a functional scoliosis, whereas a structural scoliosis, you can't really change it without a significant intervention. And the other thing to consider with scoliosis is, so not only do you get kind of this deviation to the side, this what they call a medial lateral, or I usually just refer to as just a lateral curvature of the spine, is that the vertebrae also tend to rotate with that as well. So not only do they kind of deviate laterally, but they also rotate, and that's obviously going to affect, and we'll talk about this later on, some of the issues that individuals with a significant scoliosis tend to deal with. This also tends to affect their rib cage, their thoracic region in general, which could cause further problems. So looking at some of the specific posture issues, we're going to look at hyperkyphosis. So this is when you're going to get the increased kyphotic curve in the thoracic spine. Again, various possible causes. Again, osteoarthritis, osteoporosis, thoracic spine injury, again, postural issues, muscle imbalances could certainly all do this. This is the classic. You get the humpback, hunchback, or what they call Dowger's hump. And that gets really significant, particularly in older individuals who have osteoporosis and the spine kind of weakens. In severe cases, you can get nerve impingement, pain, even impaired lung function. Again, you got to be thinking anything that would impact the thoracic spine and what that would do with the ribs could obviously impair lung function. So again, we're going to kind of talk about how to address each one of these, again, depending upon the individual circumstances. Hyperlordosis, so you get the increased lordotic curve in the lumbar spine. Here you talk about, again, various causes. Again, some of the more severe causes, again, cerebral palsy, muscular dystrophy, again, then you have obesity, osteoarthritis. Sometimes pregnancy can do this as well. Again, many times in a lot of individuals, particularly active individuals that have muscle imbalances, this can become an issue for, and usually what you look at here are a combination of tight hip flexors, weak abdominal muscles, and weak glutes. This will also cause the erector spinae to get tight as well. And we'll kind of talk about how you would address this. Now, usually when you talk about a muscle imbalance issue, the initial way to kind of address that is you kind of stretch what's tight and you strengthen what's weak. However, one thing to note, that just because something is tight doesn't necessarily mean that it's strong. Sometimes muscles that tighten could also be weak. However, it's a good idea, typically, and I've kind of done this clinically with patients that I've dealt with in rehabilitation. In most instances, when somebody has a tightness, a lot of times, at least initially, to do some type of mobilization helps, because that kind of works them out of the issue. Again, you have to kind of take that case for case, but usually what you're looking at here is a tight hip flexors, weak abdominals, weak glutes, and then you get a tightening of the low back as well. And again, this increases risk to lumbar structures, and it often causes low back pain. Again, if you have that increased curvature, there's going to be obviously stress on structures, as this would go for any one of these issues. So particularly when you look at a hyperlordotic posture, you tend to look at a lot of the posterior elements of the spinal column being kind of your source of pain. And then scoliosis, again, many times the causes of scoliosis are idiopathic, but it could include structural causes. So if you have an actual deformity of the vertebrae, and it could also be functional. And this is what I was talking about. You know, one, finding out is the scoliosis a structural scoliosis where it's actually the structure of the spine and the vertebrae, or is it functional? So for instance, something like a leg length discrepancy can cause scoliosis. It doesn't mean that there's actually anything wrong with the structure of the spine. It's just that when you have a leg that's, you know, shorter than the other, that obviously is going to change what goes on at the pelvis. You change what goes on at the pelvis, that's going to go up and cause problems at the vertebrae. And again, here, beyond just the pain and some of the discomfort associated with it, again, here we got impaired respiratory function. So again, obviously, if you're kind of changing the structure up in the thoracic region, which is going to occur, so many times you get kind of almost like a twisting that would occur at the rib cage. That's going to impair kind of how the lungs work. So obviously that would cause issues with that and cause issues with the diaphragm, which then could, you know, further also cause some issues and pain associated with how the muscles in respiration would have to work. So obviously this can affect various things as we kind of look in that region. So in looking at posture conditions, again, you have exercise recommendations. I'll kind of summarize some of the things here. Make sure you're referring to the table as well. And, you know, for your own purposes, you want to make some notes on that. But again, like a lot of things, it's going to be depending upon the cause and the issue. Again, severe curvatures, particularly when you're talking scoliosis, may require bracing or surgery. You know, you may have issues where someone may need to have a disc replacement, a kyphoplasty, fusion, you know, a fusion surgery, anything like that can possibly be on the table. Obviously, you want to also look at, you know, is someone or does someone need to take some sort of NSAID or non-narcotic drug to kind of control their pain. Again, many of the recommendations are going to be general, and again, you have to look at the specific causes. And one of the things I'm going to want you to be able to do is look at generally what you want to address. So again, here's an example here. When you talk about hyperlordosis, again, increase hip flexor and erector spinae flexibility, strengthen the abdominals, glutes, and hamstrings. So what you want to look to do here is, again, tend to stretch what is tight, strengthen what is weak. So I would say the starting point for someone who's hyperlordotic is look to address the hip flexors from a mobility standpoint, look to address the glutes and the abdominals from a strengthening standpoint. I would always say be careful with spine flexibility and spine and stretching the musculature around the spine. One of the things I've found clinically with a lot of patients, and if you look at a lot of the research on a lot of stretches, and again, this isn't me saying that stretching, low back stretches are not always wrong, and there are instances where you can stretch the muscles around the spine. However, as a starting point, I don't tend to start there. I tend to look at the musculature around the hip first from a stretching standpoint, strengthen the glutes, strengthen the abdominals. And what you tend to find is the erector spinae from a tightness standpoint tends to kind of resolve on its own. I don't tend to do a whole lot of rotational stretching and stuff like that, particularly early on with individuals, until I kind of see how they respond to the earlier things. If you look at a situation where someone has a scoliosis, particularly if it's a functional scoliosis, again, you want to stretch the concave side, strengthen the convex side. If they do have a rotational deformity present, make sure to consult with the physician to make sure that there's no risk of nerve impingement, because obviously the nerve impingement could become a problem with some of the movements that they would do. Okay, so that takes us to osteoporosis. osteoporosis, again, osteoporosis could also be a cause of low back pain and some maladies at the low back, but here we're just going to look at osteoporosis in general, first of all, and just looking at the skeleton. What are the functions of the skeleton? We look at the skeleton as being leverage for our muscles, support for the body, protection, red blood cell production, endocrine function. So it actually works in energy metabolism. We obviously know that it's a reservoir for calcium and phosphorus in our body. Osteoporosis is defined by the World Health Organization as a bone mineral density 2.5 standard deviations or more below the young normal adult score. So that is the kind of the diagnostic criteria for someone with osteoporosis. And again, it reflects an imbalance of bone remodeling where there's more bone resorption than formation. So when we kind of look at bone, our bone isn't this static structure, it's constantly remodeling. What we look at with osteoporosis is when the resorption process or the breaking down process kind of overtakes the building process. So as we'll talk about on the next slide, we have our mature bone cells, we have cells that break down bone, we have cells that build up bone. And when you get that imbalance for various reasons, and you get this constant resorption of bone without the building up, that's what would put someone at risk for developing osteoporosis. So here we kind of look at a cutout of a bone. Remember, with bone, you have your spongy bone and you have your compact bone. So your compact bone or your cortical bone, or your spongy bone, which is known as your trabecular bone. If we look here, we take out a little piece and you can kind of look at what they're showing here. First of all, you have your three different cells. You have your osteocyte, which is your mature bone cell. You have your osteoclasts, which break down bone. You have your osteoblasts, which help to build bone. So again, bone is kind of a dynamic structure where you constantly get this remodeling that is going to be taking place of your bone throughout life. And in the situation where there's, for instance, one of the things we're going to talk about is when bone doesn't get stressed appropriately, you get this process where bone resorption kind of outweighs the building up process of bone. Then other things we kind of look at from a structural standpoint as it relates to bone, they're showing you here. So your lamella are kind of sort of like your building blocks of the bone, or what we kind of look as like the main type of bone in a mature skeleton. So you have your collagen bundles and your cells, so basically it's kind of like that bone that's already kind of built, if you will, through development. Then as we look at some of the other things kind of pointed out here, you have the canaliculi, which are basically just little channels in between the lamellae, and you have also your lacunae, which are also little channels that are present kind of in between the lamellae inside the bone. So in looking at osteoporosis, again, there's primary osteoporosis, which comes in two types, and usually occurs due to age and is more likely to occur in females. So it's 8-to-1 more likely to occur in females. Your type 1 osteoporosis, or your post menopausal osteoporosis, this occurs in individuals from ages 50 to 65. This is usually going to be due to a decline in estrogen production, and again, you can kind of see the loss in bone over a 4 to 10 year period. They're kind of showing you percentage-wise what you lose in cortical and in trabecular bone over that time. Type 2 osteoporosis occurs after age 70 until the end of life, and this is a much slower type of bone loss. In both bone types that you get with type 2, you get about 20 to 25% loss in both. So again, when you talk about primary osteoporosis, you're looking at, in general, a decrease in osteoblasts. And this usually can start even over the age of 35 in individuals when you're just talking about primary osteoporosis in general. We're also going to talk about something that they call low bone density, or osteopenia, which is kind of what precipitates osteoporosis. Now, the issues that you look at with osteoporosis, probably the biggest thing that gets talked about, or the biggest concern, is the issues with hip fractures. And the issue with hip fractures is caused by osteoporosis, and in about 24% of the individuals over the age of 50 with a hip fracture, they usually die within a year after the fracture, and that's due to the significant impact that it has. Number one, obviously as you get older, you're more predisposed to health conditions, but the decline in activity that occurs obviously after a hip fracture puts a person more at risk for that. So again, we're talking about primary osteoporosis in general. Again, it's that decrease in osteoblasts that typically occurs over the age of 35, sort of precipitates that. When we look at type 2 primary osteoporosis, again, this is what I talked about that osteoporosis that occurs over the age of 70. It's a combination of factors that are going to do that. So a decreased renal vitamin D production, which is also going to affect then the calcium absorption, decreased nutrient intake, decreased physical activity, and a decrease in estrogen and testosterone. So in men, particularly that suffer osteoporosis when they're older, they also get an increase in the sex hormone binding globulin, which gets produced by the liver, and then that binds to estrogen and testosterone, which then limits bone remodeling and will negatively affect their bone mass. So then we have secondary osteoporosis, or what we would call type 3 osteoporosis. And type 3 osteoporosis is going to be initiated by the presence of another disease. Again, whether that's cystic fibrosis, anorexia, use of medications. There's other risk factors here as well as it relates to osteoporosis. So smoking, an active lifestyle, alcohol abuse, excessive protein, sodium and caffeine intake can also cause this. And again, when we're talking about, besides the increased risk of bone fractures and postural concerns, again, osteoporosis is very commonly linked to higher morbidity and mortality rates. So again, obviously something we need to be concerned about, both from a treatment and sort of prevention standpoint. So talking about some common medications that we look at with as it relates to osteoporosis. So hormone therapy is probably going to be one of the more common things that we look at getting done here. Using estrogen and progesterone are examples of different types of hormone therapy that we look at. Some of the things that we found with hormone therapy, again, this was the previously most common medication, but there has been a link to increases in breast cancer, blood clots, and stroke. So there has been some reevaluation of this again. So you should be looking at some of the risk factors. So again, it doesn't necessarily preclude it or mean that it shouldn't be utilized, but what we should be looking at here is, does the person have significant risk for these? Because that could possibly change the treatment. There's also selective estrogen receptor modulators. Again, these can reduce bone resorption but can cause GI distress. So raloxifene and tamoxifen are two examples of this. Again, the most common thing associated with that is GI distress. There is also synthetic analogs of calcitonin, which get used as well. And again, calcitonin is a hormone that is involved in calcium metabolism. It's also just generally recommended for adults particularly if you're older than 50, to take at least 1,200 milligrams of calcium a day, particularly if they're not taking estrogen. Okay, so if an individual is not taking estrogen, definitely make sure you're getting at least 1,200 milligrams of calcium a day to maintain your bone health. So again, the effects of exercise in dealing with osteoporosis. So moderate to high intensity weight-bearing exercise is the most beneficial. So again, weight-bearing exercise is always going to be better for a variety of reasons. In individuals who are starting to show signs of bone weakening, or just in prevention. because again, that weight bearing is going to be what allows the bones to remodel appropriately. Now, if someone has very fragile bones, you have to kind of lower the intensity a little bit and may have to watch some of the exercises you're selecting. But for an individual who, isn't at that point where the bones are extremely fragile, again, doing a moderate to high intensity weight bearing is going to be really important. And resistance training. So you're going to get an increase in bone mass and muscle strength. Again, if you even just think of resistance training, just what the muscles do, the stress of them kind of pulling on the bone, if you will, does kind of help increase bone mass. And then in conjunction with that, it helps improve balance and proprioception. So again, here you look at other things like reducing the incidence of falls and fractures. So, and there's research out there on this. The stronger somebody's lower extremity is, the less chance they have of falling. So that's important in, again, limiting the ramifications to someone suffering for instance, a significant fracture to their hip or just anywhere in their lower extremity. So again, your exercise recommendations are summarized in table 3.3. Again, you should include a screening as you would with anything, because again, there's going to be a big variation in individuals who are either predisposed to this or have already been diagnosed. So again, you want to kind of get a big picture thing, do your testing, look at balance and coordination issues. If they have other disease states, these are all things that you want to take into consideration. What muscle weaknesses do they have? What has been their previous level of physical activity? If it's somebody who has been exercising and again, they're further looking to kind of limit the effects of something like this, then obviously you could, have a slightly higher intensity versus somebody who maybe has never exercised in their life. They've been diagnosed with osteoporosis and they're looking to prevent further issues. Again, the intensity of the exercise may have to be a little less. Again, be sure to obtain medical clearance and implement precautions to prevent falls. So again, you want to make sure that all of that is taken into consideration. So again, mild to moderate osteoporosis, weight-bearing activities, walking or running 3 to 5 days per week, 55 to 75% of max heart rate, 30 to 60 minutes is recommended. Light intensity and low or no impact exercise if someone has severe. So if someone has severe osteoporosis, again, you're going to really want to limit the amount of pounding, if you will, particularly from running. Walking is certainly something that pretty much everybody can do, and is extremely beneficial, particularly someone with even just like low fitness levels. Just even starting walking can have a significant impact on their health. So that's something that would always be recommended, regardless. And in most instances, again, very few people are limited to the point where they can't walk, and that's something that could be beneficial for them. Again, resistance training, which is, as I talk about frequently, kind of being the missing link to most people's health. Again, here's a really good starting point. You could certainly increase the intensity, lower the intensity based on the individual's severity, what they've experienced in the past. You're going to want to think about the exercises you select, and we'll talk a little bit about exercise selection based upon, issues that the individual may have, or if they have osteoporosis and they have back pain, what are some things you want to do, don't want to do. We'll be discussing all of that, and some general flexibility training. Here we're even talking about not putting excessive stress. And again, I kind of address just low back pain like this in general, but minimize excessive twisting and flexing of the spine when you're talking flexibility training. And that's why I said, even outside of being concerned about osteoporosis, even in an individual with low back pain or spine or pain at the spine, see what you can address around the area first from a flexibility standpoint, as far as aggressive stretching and mobilization. Again, not to say it's always, in the case of osteoporosis, you really do always want to watch, because obviously we know that if you twist or excessively flex the spine, that's going to stress the bony structures as well as the soft tissue. So you always want to be aware of that.